Hi everyone, my name is Christine Young, and with my DNP project, I'm hoping to examine teen suicide in Nevada and what we can do post-hospital for these teens that have made an attempt. Looking at Nevada, in 2017, suicide was the leading cause of death in teens aged 12 to 19, and the second leading cause of death in adults ages 20 to 24. Our rate was about 14.9 per 100,000, where the national rate is 13.1. Because our population is a little bit lower, sometimes our numbers get skewed a little bit higher. However, we do have the 11th highest rate of suicides in the country, which is double the national average. However, in 2016, we were the only state to lower our suicide rate. Every other state increased at some amount. It is estimated that for every one teenager that dies by suicide, another 100 to 200 have tried. One of the largest risk factors of a completed suicide is a previous attempt. That's why it's so important for us to kind of go back and look at some of the hospital stays and what we can do for these kids once they are discharged. The CDC notes that 54% of suicides are completed by individuals with no known mental illness. And another one problem that we run into with teenagers is they are smarter than a lot of the tools that we use. They're very good at telling us what we want to hear, so they can be left alone. So kind of examining what we can do to better use our tools and be more effective with them. If we look at primary care and psych services, we have seen a huge uptick in individuals coming to PCPs for psychiatric care. From 1987 to 1997, the percentage of people who received psych medication from a PCP rose from 37.3 to 74.5%. That's huge. They have also found that about 1 in 4 patients are suffering from mental illness, but primary care providers are only typically catching about 1/3 of those patients. Since we are such a big stop for them, many of these individuals that do commit suicide, or at least attempt, have seen a primary care provider in the last 30 days. So that kind of shows us, is there more training that we need? Are there things that we can be doing since we're sometimes the only healthcare provider that these patients will see? Do we need to partner with others in the psych fields for better referrals and outcomes to kind of help prevent these suicides from happening in the first place? Which leads me to what I would like to look at and examine for my DNP project is what can we do? How can we effectively involve families after these kids have been hospitalized for a suicide attempt? Keeping in mind that not everybody does get hospitalized when they do attempt a suicide. So I would be examining those that have been hospitalized and have needed interventions from physicians. Is it a checklist that we can look at for these families to help them kind of through the next steps? Is it follow-up therapy for everyone? Is it teaching them how to effectively communicate with their children? Educating peers on concerning behaviors? I'm not sure, but that is what I'd like to look at for my DNP project. So like I said, since I'm not really sure of what my project will be implementing, I'm not sure what the outcomes that I would like to see would be. I do know that I want to talk with patient populations of what has worked and what has not. Many times we have kiddos that get inpatient therapy after they have had a hospital stay, but a lot of these kids have been in these inpatient rehab facilities 3-4 times, so it's obviously something needs to change and something's not working. So talking with those parents about what they think, talking with the patients about what they think is missing and what would be beneficial for them. Many of our patients live in rural Nevada, so they're not by a whole lot and there's not a lot to do. So is it increased access to providers? Is it a cost issue that they can't get to their closest PCP? Those are all things that I'd like to look at. Communicating with the Nevada Coalition of Suicide Prevention, the health department, physicians, social workers, everyone that has kind of come in contact with these kids and has examined it over time. My goal would obviously be for a suicide rate of 0, but I know that's not realistic. So even just continuing that trend of lowering our suicide rate here in the state would be an awesome outcome. And as far as evaluation, it would consist of whether or not these kids had repeated suicide attempts during a certain time frame. Obviously, a longitudinal study would be ideal just to kind of make sure we could follow up with them, because many of these kids may not try to commit suicide a week later. So keeping that in mind and trying to find a good time frame. Thank you all for listening to my DNP presentation. Here are some references if you are so inclined. I hope everybody has a good rest of your weekend.